Hello, everybody. Today we're going to go through the last, I would call it potpourri style lecture, where we're covering a bunch of different topics at one time. I used to spend a lot more time on these types of things, but really we're going to come back to this a lot during the disease state specific areas to coincide with your clin med course. But I do think some of this stuff is important, otherwise I wouldn't be talking about it. But there's a lot of background information here and intro stuff that I think will make sense as we discuss topics in a broader sense. So anyway, we're going to shift gears after this lecture and really kind of focus on more disease state type things. But this will be a little bit of a review that you can come back to throughout the year if you are like, well, I know Chad talked about anticholinergic things, but I'm not exactly sure what that meant. I need to go back and review that. That's really the purpose of this lecture. And a lot of this stuff I'm going to talk about the pharmacology, and then I'm going to skip some of the application side of things because we will come back to that later this year. We're going to talk about histamines, prostaglandins, leukotrienes, and a couple of other things. Let's start with histamine. So histamine is an essential mediator of allergic reactions, as you guys probably are aware. Most people know what histamine means or know that antihistamines treat allergies, right? So histamine in the body is an inflammatory mediator. It actually plays a pretty modest role in anaphylaxis. We'll talk about anaphylaxis later. Specifically, I'll talk about more treatment of anaphylaxis with respect to how you'd actually treat an active patient that way when we talk about emergency medicine a little bit, but we'll talk about it a little bit today too. But the bigger role would be the sympathetic nervous system, which we'll talk about later. But histamine certainly does play a role. It does cause gastric acid secretion. It's a neurotransmitter. Its psychiatric-related applications are probably the least understood and least pharmacologically manipulated out of all the histamine potential applications. And histamine by itself is not something useful. I mean, you could make an argument maybe that making a histamine agonist that's centrally active might actually have some psychiatric benefits in the future, but that's a little bit theoretical. If you gave somebody like a histamine analog, all you would give them is basically an allergic reaction, right? So we don't really have any role of giving somebody histamine or a histamine agonist. We're pretty much focused on antagonizing histamine receptors. We talked about type 1 hypersensitivity. There's just a little diagram that kind of explains this. And just the different histamine receptors and mechanisms of action. The really big one to think about is histamine 1, which is going to be the major driving factor for allergy response. So it's going to cause itching and maybe some cardiovascular changes, flushing, warmth, bronchoconstriction, obviously a big one, smooth muscle contraction, things like that. Histamine 2 receptors specifically work in the stomach for gastric acid secretion. So when we talk about GERD and how we shut down that process in the body, that's going to be the big thing that we'll focus on there. And then again, histamine 3 is our more CNS related one that we don't have a strong, we don't really understand the pharmacologic impact of that. Some antipsychotics we'll talk about manipulate histamine receptors. So there's some things like that. But like, for example, metabolic effects, increased food intake, and appetite related effects that you can manipulate histamine on, that might be a pharmacologic area in the future. But the thing is, it's difficult if you're trying to agonize a certain set of receptors. How do you ensure that you don't accidentally agonize all these things too, which is going to make the patient not take the drug at all, right? Because they're going to be really uncomfortable. So that's the big question here. So that's why usually we're looking at antihistaminic effects. So histamine antagonists, there's a couple different ways we can look at it. So physiologic antagonists would be something that just opposes the effects of histamine, doesn't act on histamine receptors. An example of this would be epinephrine. So epinephrine we'll talk about coming up here, and we'll talk about it during psych a little bit more. But epinephrine is going to cause vasoconstriction, going to cause bronchodilation, some other things like that that are going to functionally oppose the way that histamine works. It doesn't do anything to histamine receptors, but it can counteract a histamine response, which is why it's a major element of anaphylactic treatment. Release inhibition would be mast cell degranulation. So this is preventing histamine from being released from mast cells. And then the more common ones would be receptor targeting. So mostly are going to target histamine 1 or histamine 2, and that's where our pharmacologic agents are going to act. So I'll talk about cromolyn first. It's really the only mast cell stabilizer on the market, and the idea is it just prevents again, degranulation of mast cells, so you don't get as much histamine release to begin with. It does come as a nasal spray, which is probably the most common application of it. I think it comes orally too, but I'm not sure how effective that is. I don't think it's used very often. There might be some ophthalmic indications too, but again, the nasal spray is probably the most common one. The thing I always think about cromolyn being effective in is for allergic rhinitis in pregnancy. A lot of times we're hesitant to use things like alpha constrictors or alpha blockers or vasoconstrictors, which we'll talk about here in a few slides. And I'll talk about those examples because they can possibly have problems with blood flow to a developing fetus. And in this case, this doesn't really have any interference, so it is pretty safe in pregnancy. It's also over the counter. But outside of just basic allergic rhinitis, like we don't use this for asthma or anything like that. So it's just doesn't have a ton of application out there, which is why it's over the counter. Relatively safe, also not super effective for a lot of conditions. First generation antihistamines, so everybody probably has heard of Benadryl or maybe even taken Benadryl at some point in their life. It's a common over-the-counter antihistamine, and it's available over-the-counter and prescription. So the prescription products are usually a little bit higher strength. It does come IV-IM as a prescription product. So if somebody is having active anaphylaxis, we're going to give them IV Benadryl usually. It's the same dosing as oral too, which makes it easy. Multiple combination products. A lot of people take this as needed, and a lot of people take this for all types of different indications. So allergies and sleep aid are probably the two most common ones. It also is a somewhat effective antiemetic or useful for motion sickness. So always think about how you recommend people take Benadryl. And I always wonder about people who say they take Benadryl for sleep every night. The thing about taking Benadryl for sleep is a lot of times it is a bit anticholinergic, which we'll get here to in a second. So I'm putting the cart ahead of the horse, the cart ahead of the horse. So, right. Anyway, I'm getting ahead of myself a little bit, but the point is that you have different effects that the drug has besides its antihistaminic effect. It's also anticholinergic, which, at this point, I'll just say it makes you sedated usually. So that's the sedation component of Benadryl. And the reason why that's a problem is that's part of it anyway. The histamine crossing the central nervous system or crossing the blood-brain barrier, acting on H1 receptors in the central nervous system also causes sedation too. But the point is that you can get a little bit of negative effects from the drug's anticholinergic profile, which we'll talk about in detail here in a few slides. And that can make people feel crappy. So after you wake up, you just feel kind of junky. I've heard people say you kind of feel hungover after you take Benadryl. I don't know. I've never really taken Benadryl, so I don't know exactly what the effects are personally. But it's a sleep aid that is available over the counter. It's a fairly potent sedative as far as over-the-counter drugs go. So I'm not surprised people use it that way because they can get access to it and it's easy. A lot of times they'll have like a person who comes in and they take it. And I always ask, like, oh, do you ever feel groggy in the morning or anything like that? I'm like, nope, it works great. And so I don't really get too worked up about it. It's technically not probably the most appropriate sleep aid out there. But if you're using it for that and you're not really having any effects and you're only taking a pure diphenhydramine product, that's my biggest thing too. These products are, diphenhydramine is combined in a lot of different products. So Tylenol PM, Advil PM, and then pretty much every cough and cold product on the market probably has some diphenhydramine formulation. So you do have to be careful. If, for example, somebody's taking Tylenol PM and they're taking a bunch of acetaminophen and they're already taking acetaminophen for pain throughout the day, you could end up actually accidentally overdosing yourself on something like that. So anyway, talking probably a lot of layers here that's branching out into other things we're going to talk about. But the point is that diphenhydramine has a lot of applications out there. And it's just, when are you going to appropriately use it? I think the best time to use diphenhydramine probably is for if you have allergies and you also, so like if you're having trouble sleeping and also due to allergies. So like, let's say, I don't know, you're visiting relatives or something and they have a cat and you're allergic to cats and you just need something to help you sleep and get through the night and prevent that histamine response from happening. Benadryl is a great choice for that. Another one, we'll talk about hydroxyzine, and we'll talk about hydroxyzine a few other times here and there. It's pretty similar to diphenhydramine, but it's slightly less anticholinergic and it's less sedating. It's used frequently for narcotic-induced pruritus or itching, and you'll see that a lot if you work inpatient, or especially if you are working for a surgical group and you do a lot of post-surgery order sets. You'll see this as a common one. So if you prescribe somebody oxycodone or morphine or whatever opioid, a lot of times people get opioid-induced itching. It's just part of the mechanism of the way opioids work. They can release histamine, and so this can help prevent that. So it's a really common use for that. It also has a lot of psychiatric applications. They use it a lot for anxiety and other odd things like that, which I'm not going to get into right now. It's a little complicated, but we'll talk about that more when we talk about psych meds. It does come PO, IV, and IM, but it could be used for allergies. There's no reason it's not. Diphenhydramine is generally preferred. It's a little bit more of a potent antihistamine, and that's why in like a severe reaction, we would give that over hydroxyzine. Some other antihistamines, brompheniramine. I just put this on there because you might see it on the list or on an ingredient list on a cough and cold product over the counter. It's thought to, I don't know why they combine it with cough and cold products. If you have a cold, an antihistamine really isn't going to help you, but it's probably slightly sedating, which is why people take it. I don't know. That's the best I can think of. Another thing is promethazine, which is similar to diphenhydramine. It's kind of an odd drug. It's antihistamine, it's anticholinergic. It also has similar structure to older antipsychotics, and it's got some alpha and dopaminergic effects, which doesn't mean much to you probably right now, but we'll talk about those as we get through the course. And this has been abused by, I put the the term here, this has been abused by numerous rappers throughout the last decade, probably. Lil Wayne was notoriously hospitalized for seizures after overdosing on mixing promethazine codeine. But the big thing that causes seizures is actually the promethazine component. Codeine would just make you sleepy and maybe cause some respiratory depression if you drink a bunch of it. It's an opioid. But promethazine is a little bit nasty when you take a ton of it. So that's why people don't do too well when they drink a lot of this product and abuse it that way. All right, second-gen antihistamines. So these are much more popular, and they're, as far as allergy medications, they're probably the mainstay for anyone who has allergies. And they're long-acting, which is nice. They're once daily dose. They're non-drowsy. They're over-the-counter, and they're generic, so they're relatively cheap. Most people can take these without any side effects whatsoever. Every once in a while, I heard some people tell me that, when I take Claritin, I get really sleepy. Doesn't really make sense that you'd get sleepy off Claritin, but unless you're taking a lot of it. But it's possible, I suppose. The other thing you might see these drugs is combined with pseudoephedrine. So you see them like Claritin D. Oops, it's not letting me do it. Oh, there we go. Claritin D, like a brand name like that. And that just means that it has the decongestant associated with it, which would be pseudoephedrine, which we'll talk about. Most of you guys probably know what Sudafed is, but we'll go through a little more detail on that here in a couple slides. So big takeaway of these drugs, super common. So you guys have probably all heard of these brand names. They're interchangeable. They all do the same thing. None of them have been clinically studied to be better than the other. One thing is that loratadine has been shown to be sedating at high doses, but you shouldn't really need high doses to get the antihistamine effect. Anyway, if somebody does report sedation, just switch them to another one. Switch them to fexofenadine or cetirizine. The reason why these are non-drowsy is because they don't cross the blood-brain barrier. And that's the big mechanism behind why Benadryl is so drowsy, so sedating. The other thing is these aren't very anticholinergic. So Benadryl has two strikes against it as far as the sedation issues. It's anticholinergic, and it's a histamine 1 antagonist that crosses the blood-brain barrier. These drugs are not anticholinergic, and they don't cross the blood-brain barrier, which means that they don't cause any sedation. They just act peripherally, which helps with all those annoying side effects like the itching, runny nose, itching eyes, that type of stuff that people get with seasonal allergies. And that's where these drugs are going to be still effective. You don't really need an antihistamine to cross the blood-brain barrier to do anything about an allergic response. So these drugs are great. They were prescription when they first came out, but they've widely been over the counter for several years now, and people self-medicate with them all the time. There's very little risk in taking any of these, and that's about all there is to it. A couple little pearls: fexofenadine. Avoid fruit juice before or after taking. It just makes the fexofenadine less effective if you take fruit juice with it. So some of those things will come up. Mostly it's citrus fruit or grapefruit juice, which is the big culprit. But at the end of the day, I don't think the majority of the population drinks enough to avoid it, to make a big difference. And it can manipulate the hepatic enzyme metabolism of fexofenadine. So anyway, you might want to tell patients just to wait a couple hours before they drink fruit juice so that the fexofenadine gets absorbed and through the liver and doesn't go through like a really extensive first pass metabolism or something like that. Anyway, cetirizine, nothing really to say here. It's pretty well tolerated med. There's levocetirizine, which is you can see, obviously it shares the same name here, just a different enantiomer. Whoops, did something wrong. Just a different enantiomer, and the brand name is Xyzal. No difference. Every once in a while I see somebody on it, and I always kind of scratch my head as to why you'd actually need. I suppose you get the odd patient, 1 out of 1,000 patients you see will come in and say, I've tried Claritin, Allegra, and Zyrtec. None of them work. What else can I try? And you're like, well, what about this new drug, Xyzal? Let's give it a shot. And sure enough, it works. So again, 1 out of 1,000, right? Not a common occurrence. H2 blockers. These drugs, again, super common. You guys have probably heard of all of them. They're over the counter as well. They're commonly used for heartburn, stomach acid production. We're going to talk about these in detail during the GI lecture. So that's all I'm going to say now. Okay, that kind of summarizes histamine. As far as what to know for this from an exam purpose, I just have an idea of what the drugs do from a mechanism point of view. I'm not going to test you specifically on things that we didn't talk about. So for example, I'm not going to ask you about stomach acid production and famotidine, or which one of these would be preferred to use, because we haven't covered that information yet. What I might ask you is which one of these antihistamine drugs targets H2 receptors specifically, and then you might have to recognize that. So that's where I'd be getting at. Focus on mechanism of action. And then I might do a patient case about allergies, since we talked about this specifically. We aren't going to come back to these drugs ever. This is all we're going to talk about with allergies. I have a little bit of an ENT summary at the end of the lecture. That's more of where the clinical stuff will come from the case-based things from this particular exam, for this lecture, I should say. All right, anti-inflammatory pharmacology. A lot of this we're going to come back to at various points during the course. So again, we're going to go through this pretty quickly. I talked about this briefly with steroids, but anti-inflammatory processes all kind of have the same pathway where some sort of trauma or manipulation or stimulation happens that causes membrane phospholipids to release arachidonic acid, which causes a downstream cascade. You get different enzymes that manipulate arachidonic acid, so cyclooxygenase enzymes, lipooxygenase enzymes, and then you get various mediators there that are going to cause different causes. So for example, leukotrienes, we're going to talk about a little bit more with respiratory, but those can cause effects in the lungs and the pulmonary vasculature, and how we can manipulate that to prevent asthma attacks. Thromboxanes will have effects on how platelets aggregate together and form clots. So at this point, we won't discuss this really further, but during cards, we're going to talk about aspirin and other things like that modulate this type of effect in detail. Prostacyclins and prostaglandins, mostly relating to NSAIDs and non-steroidal anti-inflammatory drugs like ibuprofen, and those are going to prevent some of these inflammatory mediators which are associated with causing pain. So if you have an injury and you have your body's producing arachidonic acid and all these things are getting upregulated, you're going to have inflammation, which puts pressure on nerve endings, which causes pain. NSAIDs can prevent that from happening, at least to a certain degree. And then therefore you don't get quite as much of the response, and hopefully you can be pain-free. So that's the point there. We're going to talk about pain in detail on, I believe it's the first lecture slotted for the spring. So that's really all I want you to know from a mechanism. I've put some stuff in here that talks about the different COX enzymes, but we're going to go over this again. But if you want to review this and look at this now, certainly go ahead. This is really the background when it comes to non-steroidal anti-inflammatory pharmacology, and that there's different cyclooxygenase enzymes. Some are constantly active, so cyclooxygenase active enzymes upregulate housekeeping prostaglandins, which are great. They help with things like gastric epithelial protection, and they're good to have around. COX-2 is more upregulated depending on the stimulus, and that's really more associated with pain syndromes. So NSAIDs have to target, a lot of them target both. They aren't selective. And so just for an example, if you've ever heard of like ibuprofen, people taking a lot might cause a GI bleed. That's because it inhibits COX-1 and COX-2. So COX-2 inhibition helps with the pain management if you take ibuprofen, which is Advil or Motrin or whatever you want to call it. And COX-1 is the casual, like the innocent bystander that gets knocked out at the same time. And then you lose some of your gastric cytoprotection, putting you at higher risk for GI bleeding and ulceration. So that's why NSAIDs can be a little bit dangerous for people with high risk factors. And again, we'll talk about this extensively, but I just wanted to give that as an example while we're talking about it today. Lipooxygenase, leukotrienes have a component in asthma and anaphylaxis. Again, there's some drugs out there that antagonize receptors, and we'll talk about these more next week when we talk about respiratory. Prostaglandins, prostacyclins. We're going to talk about glaucoma and prostaglandins in a lecture today as well during the glaucoma treatment pathways. And we're going to talk about pulmonary hypertension during CARDS. We'll talk about the OB applications during OB. So again, that's all I really want to talk about now. I drank coffee with Benadryl this morning, and this person is confused. Yeah, caffeine and antihistamines might not be the best thing to mix. All right, autonomic nervous system. A little bit more meaty stuff, but still similar. We're going to breeze through some of this just because we'll come back to a lot of it in much more detail. So, some background information. The nervous system breaks down into a couple different components, as you guys know. The peripheral nervous system has a few major pharmacologic targets, and they basically break down into our sympathetic nervous system and parasympathetic nervous system. So sympathetic being the fight or flight, parasympathetic being rest or digest, housekeeping, however you want to think about it. You've got two major neurotransmitters that we're talking about as our core endogenous mediators of these two systems. And then from a pharmacologic aspect, that's where we go to manipulate them. So acetylcholine is the boss of the parasympathetic nervous system. It's responsible for our rest and digest functions. So if you ever hear a drug described as cholinergic, anticholinergic, or an acetylcholinesterase inhibitor, they all are manipulating acetylcholine to a certain degree. We'll talk about why that matters in some instances here. Norepinephrine is the boss of the sympathetic nervous system. You're responsible for your flight or fight response. I think a lot of people call this adrenaline, which it's technically is norepinephrine. So any drug that works on alpha or beta or even some dopamine receptors, drugs referred to as stimulants or pressors, or a lot of our, I'm not going to say a lot of our blood pressure medications, some of our blood pressure medications, but think about like a beta blocker. Most of you guys have probably heard of a beta blocker before. That's antagonizing the system. So think about it. When you have well, actually, I'm getting ahead of myself here, so I'm going to explain this in more detail when I actually get to the slide instead of doing it now and repeating myself. So anyway, hold that thought. Let's talk about this while we're talking about receptors and things like that and the actual neurotransmitters. So sympathetic and parasympathetic, some of the big differences to think about is that the parasympathetic nervous system always operates on acetylcholine. So you've got preganglionic fibers that target nicotinic receptors with acetylcholine. You also have the same thing here. So the sympathetic nervous system isn't any different except for their preganglionic fibers are short. And when acetylcholine stimulates it, you release norepinephrine, and that targets an alpha or beta receptor. So you are having a pretty similar process here, yet a different process at the end of the line here. And that's where selectivity becomes really important from a pharmacologic aspect, because if we're targeting acetylcholine nicotinic receptors, you can get all types of crazy responses. So if you agonize these two receptors without any thought for what you're going to happen downstream, you're going to get tons of different effects, which could be both aspects of the autonomic nervous system would be affected then. So you're actually getting antagonizing effects. Your rest and digest system would be kicking up, and your fight or flight response would be kicking up. So that's why we selectively target certain things. And then with this stuff, we'll drill really down into some of these different ones. So for example, beta receptors have subtypes. Muscarinic receptors have tons of subtypes, and there's different ones on different tissues. So if you can target something specifically for a subtype that's only on the bladder, for example, you can help with urinary incontinence and not really affect any other systems. So that's really where we're going with some of the intro topics here. We'll get there eventually, just to give you a clue as to how this all works together in the body. All right, so let's talk about the parasympathetic nervous system first, our rest and digest system. So remember, acetylcholine targets acetylcholine receptors, and there's two different subtypes, nicotinic and muscarinic. For the most part, from a pharmacologic point of view, we're almost always looking at muscarinic receptors. There's very little use in targeting a nicotinic receptor because of what I just said. That's way too broad of a response, and pharmacologically, it just doesn't make any sense to do that. You're probably thinking, well, what about nicotine? I'll get there in a second. The housekeeping system, so fuels your body, promotes growth, removes waste, and our drugs are going to target a couple things: release of acetylcholine, mimicking acetylcholine or binding of acetylcholine receptors, and bioinactivation or altering the metabolism of acetylcholine. All right, so let's talk about that nicotinic receptor just for a second. Ligand-gated ion channel, potassium and sodium channels or influx causes depolarization, preganglionic stimulation of multiple different things. So that's it. That's too broad for really our use here. I will talk about this stuff a little bit when we talk about anesthesia briefly. Not that any of you guys are here to become anesthesia providers, otherwise you probably would have been a nurse in a CRNA program. So that's not really relevant to us, but I will talk about paralytics and things like that briefly when I do a little bit of an anesthesia module in the fall. So this is just not relevant at this point in our careers. Muscarinic subtype, again, this is really where we're looking at manipulating pharmacologically. So you got different M-type receptors that are located in different areas. For example, M2 and M3, smooth muscles, cause contraction, vasodilation, which can help in certain indications. And then you have specific subtypes within these receptor subtypes that allow you to be selective to various areas of the body. So you can actually get anticholinergic drugs that are really selective and have very little side effects because they're so tissue selective. And that's really the goal with a drug, is that you get it to the right spot and really keep it at that spot only and don't let it get elsewhere. Otherwise, it's going to cause side effects. This diagram shows you the pathway of acetylcholine, and it does show you some things that we're going to talk about as far as where drugs work on it. So, for example, like degradation of acetylcholine. Acetylcholine is rapidly hydrolyzed by acetylcholinesterase in the synaptic cleft. So what that means is that when we give somebody an acetylcholinesterase inhibitor, that prevents that from happening as frequently. So you get a buildup of acetylcholine in the synapse. Therefore, you can use more of it. So where is that advantageous? In Alzheimer's disease is where we use that type of pharmacology. Another example, release of the neurotransmitter, blocked by botulinum toxin and also spider venom. So we'll talk about, botulinum toxin, aka Botox, is where this works. So we'll talk about that here in this slide, and I'll go into a little more detail on that. All right, cholinergic mnemonics. I hate mnemonics, and I think they're really annoying, especially like dumbbells, which, I mean, okay, you have 2 B's, 1 L, and 2 S's. Like, who's going to actually remember that? But I really like SLUD. It's easy to remember. Salivation, lacrimation, urination, and defecation. I think if you ever agonize the cholinergic system, so we're talking about postganglionic parasympathetic nervous system, acetylcholine, muscarinic receptors, broadly, this is what you're going to get. You're going to get salivation, tearing up, and then incontinence. So is there any real pharmacologic reason for us to do that ever to somebody other than, to be cruel and unusually punish them? No. The point in this is that pure drugs that manipulate cholinergic activity from an agonist point of view are simply not useful unless they're very focused, and we'll get to some of that stuff. These side effects are not things that we want to cause in people generally. So is there any application? Well, there's a couple things here, and I'm not going to test you on anything on this slide. Basically, if you are hiking around in the woods, I was just up at the North Shore on Lake Superior with my wife, and we saw all kinds of crazy looking mushrooms, and I'm pretty sure a lot of those would have caused some of these types of effects if I were to have consumed them. Fortunately, I'm not an idiot, and I'm not going to grab a bright yellow mushroom and eat it. But you never know what happens, right? So if you get somebody calling you saying they found some odd mushroom in their backyard and decided to consume it, and now they feel really sick, well, that's a typical mushroom poisoning. A lot of them are not overly toxic in the sense that they're going to kill you, but you might get really, really sick, like GI upset, violently vomiting, stuff like that. So that's because of these cholinergic activities that a lot of mushrooms have. Some actually have anticholinergic activities, which is a whole other ballpark and a little bit more complicated too. So anyway, let's talk about nicotine briefly. I'll do a whole lecture on smoking cessation, and we'll talk about that during the psych module. But the point in this right now is that nicotine does work on those nicotinic receptors. So nicotine is an interesting compound that stimulates both the parasympathetic and the sympathetic nervous system at the same time. So when I said that we don't ever use something pharmacologically to do that, I kind of lied, because we do, in the sense that we replace nicotine itself. So the idea is that nicotine alone, if you just like nicotine, like if you're just taking nicotine powder and consuming it, and that you like the effects of that, great. But it's the rest of the stuff in cigarettes that causes problems, right? So if we can supplement the nicotine by removing the actual cigarette and just providing the physiologic effects, you can hopefully get somebody to quit smoking that way. So that's what we do. So pharmacologically, we do stimulate those receptors, but it really is only in this specific instance. And there's a bunch of different products out there that come as nicotine replacement, and we'll cover those extensively when we talk about that next spring. We will also talk about acetylcholinesterase inhibitors later. The thing about them to remember, just for right now, because you're just like, you just told us that cholinergic agonism and stimulating, basically being pro-cholinergic, and how you're manipulating yourself pharmacologically is bad because you get SLUD and dumbbells, right? Well, if you decide to make this only work in the central nervous system, you're actually onto something interesting here. So the idea here is that in Alzheimer's disease, you have a marked cholinergic deficit in the brains of Alzheimer's patients. So by preventing the degradation and metabolism of acetylcholine via acetylcholinesterase, you can increase the prevalence of it with very little systemic side effects. In fact, there's virtually no systemic side effects for a lot of these drugs that we're going to talk about. There aren't many out there, and I'm not going to talk any more about that other than that they have an application for Alzheimer's disease, and just knowing that they break down. So if I talk about, I'm not even going to really talk about the drug specifically, but if I talk about an acetylcholinesterase inhibitor and how it works, just understand that it's interfering with the metabolism. So you're going to increase neuronal synapse presence of acetylcholine. That's how we do that. The other thing I've got on here is procedural application. So again, not really your cup of tea. This is a anesthesia type thing. But if you paralyze somebody, you can, during a procedure, so they aren't moving, you can reverse them with, usually we use neostigmine for that. You can also use physostigmine. I've used this occasionally in the emergency department to diagnose somebody as overdosing on an anticholinergic product. So let's say, like the case I had most recently was an older lady. She had probably taken too much Seroquel, which is an antipsychotic that has some anticholinergic properties. And so to see if we could up her acetylcholine to overcome those anticholinergic properties and see if that would resolve some of her symptoms. She's just kind of altered mental status, not really aware, a little bit sedated. We gave her some physostigmine, and actually she kind of popped back up and was really normal for a few minutes, and then physostigmine is really short acting, and then so she went back down into it. And the provider I was working with, who's actually a toxicologist, like, there we go, anticholinergic toxicity. So it's pretty interesting that you could do stuff like that, but very limited applications. And again, I'm not expecting you to know anything that I just talked about, because that's pretty advanced, and we'll get to it more as we talk about psych meds and we talk about emergency medicine next summer specifically. All right, cholinergic antagonists. So these are anticholinergic drugs, also not super helpful for a lot of situations. The problem is, so I've got the side effects here. There's all these nifty little names for anticholinergic side effects, and we'll talk about that more when we talk about toxicology next summer, specifically anticholinergic effects and why we care. But hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter, tacky as a polyester suit's the one I always like to add because people get tachycardic. What I would say is that these aren't desirable effects, right? So this is just as bad as the opposite of cholinergic agonists. So both of these pharmacologically aren't very helpful. And the thing is that so many drugs have anticholinergic effects simply by the nature of how their molecule is. So the molecule just happens to be similar enough to histamine, where it binds to receptors and blocks histamine from actually doing its normal housekeeping jobs. So you get some of these problems, and it's really common. It's a really common side effect of a lot of medications. So it's really important for you to understand this, because throughout the whole course, I'm going to talk about anticholinergic and say, well, that drug's really anticholinergic, so we don't like it. We might like this drug in the same class because it's not as anticholinergic. That's the really important differentiating aspect when it comes to picking drugs sometimes. We don't like anticholinergic meds except in a couple situations. So classic anti-muscarinic things, clinical applications, not a lot of things here. If somebody is over-secreting, like if they're drooling a lot, you can give some sublingual atropine, which is a pure anticholinergic agent. It has some use in bradycardia, symptomatic bradycardia. So if somebody is really brady, like they have certain types of heart blocks, you can give IV atropine, and that can hopefully overcome that heart block a little bit. Possible antidote use, if you had a cholinergic overdose, like a mushroom thing, maybe. But even in that case, you're probably just going to let it wear off. You aren't really going to give them anything. And you might use this, actually, anticholinergic drugs pre-procedurally for ophthalmic indications is pretty common. So there's something like that where it actually opens up the pupil, right? That's a good instance of using this, but that's really specific, obviously, and we aren't having much more of a discussion around these drugs other than that. A couple things we'll come back to: antiemetics, respiratory indications, urinary incontinence. I talked about this. This stuff is all getting much more focused on where it's being used. So like ophthalmic and respiratory, anticholinergic can be great, but the nice thing is that you aren't giving it systemically, so there's no risk of side effects. Urinary incontinence, we really want to focus on muscarinic receptor subtypes that are at the bladder specifically. So there's those types of things that we look at. I'm talking about Botox really quick because we don't really talk about it at all, and it's a really common thing that's done. You may or may not ever encounter it in your career. Where I see it used is in our rehab facilities that we do, either outpatient or inpatient. We do a lot of stroke care at Abbott, and people who have strokes or spinal cord injuries or things like that tend to have chronic spasticity sometimes. And so what you can do is actually inject Botox into the muscle that's spasming. So I actually did a major project around this when I was a resident, around our cost on Botox and how we're using it, and if there were better alternatives, etc. Not important at this point. But for example, I spent a day with a rehab doc and watched him inject Botox into people. And I wish you guys could see me because I'm doing funny things with my wrists right now, but you just have to imagine. And I don't feel like turning my webcam on. So this patient had like a really flexed wrist. So pretend like you're making like a duck head with your wrist, and her wrist was always just sort of like that. And the problem with that is you can't use your hand really. That's one issue. And then otherwise, it just kind of clamps up everything. It's hard to put clothes on and off, stuff like that. So it's just there's a lifestyle issue. She actually recovered from her stroke really well, and she was she had a pretty good quality of life, but this was really one of the major residual symptoms for her. So what he would do is actually inject Botox into her forearm nerves, at different points, and that would relieve her spasticity. So the thing is that Botox, the mechanism behind it is that it prevents the release of acetylcholine. And what that does is it prevents action potentials from occurring. So those nerves that are just overacting and causing your muscles to clench up permanently or too aggressively relaxes that. And it's a cool process because the art form behind it is you want to give enough where your arm's not just limp and flopping around, you can't move it. You want to make sure that you can still have some activity there. So it actually is a very effective treatment. So that's an example. If you're thinking about Botox, you're probably like, yeah, that's just cosmetic. It's actually not. There's a lot of great clinical applications to it, and that's just one example. Chronic migraine, excessive sweating, which is more of a cosmetic thing, but those are also areas where Botox is used too. So again, kind of anticholinergic effects ultimately. Botox is super toxic. It's like one of the most toxic substances on earth. If you ingested a bunch of it or injected it into somebody's vein, you could be in big trouble. So the way that you have to do Botox, you have to be very well trained to be able to do it, so it's not actually absorbing systemically. And that's a big part of it. But it's actually really safe if you know how to do it. All right, sympathetic. Switching gears here a little bit to the other side of fight or flight. This is our reactive system using fuel, stopping non-essential physical processes, shunting blood to the core, halting of the parasympathetic. So if you ever somebody was so scared they pooped their pants, you might think, well, I thought that if you got scared, it's the fight or flight response. The thing is when your sympathetic nervous system kicks in, all of a sudden you get immediate halting of that parasympathetic response. So what happens is you actually get a loss of tone in the GI tract and bladder, which is why you can have episodes of incontinence when somebody is truly terrified of their situation. It's because their body's kicking in a ton of norepinephrine, and you just aren't used to that, and all of a sudden everything goes relaxed, and you can have, again, episodes of incontinence. Drugs target catecholamine native sites, or beta receptors, alpha receptors most common, and we'll talk about some more of this stuff as we go. So anyway, you wake up and find a tiger in your hotel room, like the great movie The Hangover. What tools do you need? So the idea here is you are increasing hemodynamics, increasing heart rate and blood pressure is what I mean when I talk about hemodynamics. Vasoconstriction, blood shunting, that's going to shunt things back to the core, and it's going to make your heart pump faster and harder so that blood and fuel is getting to where it needs to be. Bronchodilation, your lungs open up, allowing you to take in more oxygen, which is, of course, good. Increased muscle tone, and glucose. So the whole system is set up to improve your body's pump, your heart, and make sure it can pump all that extra oxygen and blood to muscles so that those muscles can be used to fight or run away. Here's some different catecholamines that exist. So you can see that everything's actually synthesized from the same thing. So phenylalanine gets synthesized into tyrosine, into dopa, into dopamine, into norepinephrine, into epinephrine. These are catecholamines that we manipulate pharmacologically a lot, and they're all pretty much the same structurally, and our body just makes one off of the other. Just a diagram on how everything lines up as far as the preganglionic, postganglionic effects. So here we have our acetylcholine receptors. Here's our norepinephrine, heart and vessels, renal vessels, etc. The primary receptors we're going to talk about are alpha and beta. We'll talk about dopamine a little bit too. But alpha receptors in the blood vessels, smooth muscles, prostate cause vasoconstriction. Beta 1 is mostly cardiac. Beta 2 I like to think of as lungs, but also other areas of the smooth muscle. And the big things you're going to see here is smooth muscle relaxation, vasodilation in the pulmonary vasculature, again, opening up those lungs. Dopamine 1 improves blood vessel and expands blood vessel and blood flow to the kidneys. So it's nice in the sense that it keeps your kidneys with this increase in sympathetic tone. You've got things that cause vasoconstriction and increased heart rate and things like that. And they're pushing blood into different areas, and it could be easily thought of that your kidneys get kind of hurt in the wayside. And actually, over time, if you're in severe shock, your kidneys will fail. But the nice thing is that the dopamine receptors will also be activated usually, and that can help keep the kidneys going with some extra blood flow there so that they aren't getting completely cut off via vasoconstriction. Some mechanisms of action. I'm not going to talk about this stuff in too much detail. I don't think it's relevant to the course, other than that it is pharmacology. So it is how the receptors work and how they work on a molecular level. So you have phospholipase C, adenylyl cyclase. It's interacting with cyclic AMP, and that's going to cause contractions. We'll talk about a little bit more of this when we talk about the drugs specifically. And talk about some of this from a cardiac perspective. So from a cardiac perspective, you have adenylyl cyclase, cyclic AMP, and calcium ions that are being the mediators here. So in this diagram, you can see the sympathetic, whoops, what's going on here? I just messed something up. Hold on, sorry. There we go. All right, so our norepinephrine gets released. And these are beta receptors here, right? So we've got beta 1, beta 2, it doesn't really matter. I'll just say whatever it is. You get a chain reaction that causes cyclic AMP to open up calcium channels, which causes an influx of calcium into the cell. So one thing to remember, if you ever read about something that opens calcium channels and causes calcium influx into the heart, calcium is generally an ion that causes contractility and excitation, meaning that you get a contraction response. So that's why you get these powerful, more powerful contractions and more frequent contractions in your cardiac myocytes. Now, if you block the receptor, you can understand that doesn't happen. So actually, that's calcium channels are the driving force here behind what's going to happen if you stimulate a beta receptor on a cardiac myocyte. Alternatively, on the smooth muscle, you get basically the opposite effect. So beta agonist So norepinephrine again. Let's say your norepinephrine's coming down here. It hits this beta receptor. You actually get calcium leaving this. You get an increase in cyclic AMP, and the calcium channel actually ends up getting cut off and left behind. So you don't get as much calcium. You get a negative feedback loop, and the calcium doesn't get influxed into the cell. Therefore, you're getting a more relaxation response. So beta receptors do different things in the heart than they do in the smooth muscle and in the vasculature. So that's the important thing to understand, is it has to do with how the calcium channel is being operated. And in the smooth muscle, it actually basically cuts it off. And in cardiac myocytes, it opens it up. It's a little bit different, but same physical process as far as what the receptor is doing. It's agonizing the receptors. All right, so some drugs out there that affect, this is just to show you. We'll talk about this more when we talk about cards and we talk about emergency medicine, so I'm not too worried. But there's different drugs that manipulate. A lot of drugs that act on the sympathetic nervous system hit a lot of different receptors. That's my point in showing you this. So norepinephrine has a lot of effects there, less so on beta 2s, mostly on alphas and beta 1s. Epinephrine pretty much works everywhere, and there's some other things here I've got for you too. Shock and CV emergency, we'll talk about this again during emergency medicine and critical care, but shock is a significant reduction of systemic tissue perfusion, resulting in decreased oxygen delivery to tissues. There's cardiogenic, septic, and hypovolemic, and they can all have different underlying etiologies. Septic shock we talked about a little bit with respect to sepsis and systemic inflammatory response from an infection. That's a pretty common presentation. But cardiogenic shock could be like a patient with heart failure whose heart is, maybe late stage heart failure, and their heart's just not pumping adequately. CV emergencies, basically shunting blood to the core and kicking the heart is how we handle that. So if somebody's heart is failing, we want to push blood to the core. We want to stimulate them with something that's going to hit those beta receptors. Some other applications, blood pressure. Talk about this extensively during the next module in cardiology, so I'm not going to get to it. And we'll talk about respiratory next week. There's beta receptors there. OB, again, beta receptors there, so we'll come back to that during OB. Okay, let's talk about ENT applications and how we might treat some standard ENT-related concerns. So a lot of times you're going to get seasonal allergy complaints, rhinitis, maybe even the common cold. All those things could be considered possibly inflammatory in process. So one thing that we talked about last week, corticosteroids, we'll bring up again. So corticosteroid applications, nasal sprays are really effective for this. The one disadvantage of the nasal sprays, they're probably the most effective topical product for seasonal allergies. They just are slow to take effect. So if you're traveling and you get into a new environment with allergies and you want something fast, this probably isn't going to work. It certainly might help a little bit on day one, but you aren't really going to get the full effects of a topical corticosteroid until you've used it for about a week. Fluticasone, flunisolide, mometasone, there's Flonase, Aerospan, Nasonex. Flonase is over the counter now, which makes it easy to get for people. I can't remember, I don't know, Nasonex might be now too. Safe in pregnancy, so that's a nice advantage for pregnant people who have kind of chronic congestion. They could try these. As needed usage, so some people are like, oh yeah, I just take it, when I need it. Well, technically that's probably not the most effective way to use these. You should probably take these for a sustained period of time to really get the full benefit. If you take it like once a week, you probably aren't going to see a huge advantage in your symptoms. So the overlying message here is these are great drugs to recommend for somebody with seasonal allergies who knows that they get spring allergies for 3 months straight. Have them use this every day, and they should see pretty significant symptomatic improvement. I've used like a Flonase inhaler when I've had colds before, and I do think it helps a little bit. I'll talk about some other options, but it's nice because you can sustain your use and you don't get diminishing returns or issues with rebound vasodilation and issues with that. So antihistamines, certainly an option. So the oral second gens should be top of the list for something that you're going to be offering patients or recommending to patients as an anti-allergy medication. So along with nasal corticosteroids, I think these are probably the second or first line choice that I would recommend. First generation, again, okay, but try and use them at bedtime. Most people won't tolerate it during the day. I will mention the paradoxical effect on children. Sometimes kids, when they take Benadryl, get really hyper or a little bit delirious on it. The reason being is because it is fairly anticholinergic. Children are at high risk for anticholinergic toxicity because they're just more sensitive to it. And so basically you're poisoning your child if you see that result. No, I don't want to be mean like that, but that's actually what's kind of happening. Your child can't handle the anticholinergic effects like an adult can. So instead of making them sleepy, they basically get CNS toxicity off of it. It's not a problem. It's not like you have to bring them to the ER or anything. It'll just wear off. But it is annoying if you're expecting your child to sleep on a plane ride and you gave them Benadryl and they're bouncing off the walls and acting psychotic. So not that that's probably a stretch, but still, you guys get the point, right? It's the opposite effect. So if you're going to use that or recommend a family member try that for a child, I don't really have any problem with drugging your kid on an airplane. As a parent who's had screaming children on airplanes with them, I get it. I personally have never gone there because I've never had the foresight to actually test my child with it beforehand. That's probably the way to do it. So try it while they're at home someday and see if they react to it, like before nap time, and then that would maybe give you a clue if you could use it on a plane. Remember, a cromolyn mast cell stabilizer is an option as well. Pseudoephedrine, so these are sympathomimetic applications. So Sudafed or pseudoephedrine is an alpha and beta agonist. It's somewhat selective for alpha receptors in the respiratory mucosa, but you will get bronchial and cardiac side effects. So people will usually feel jittery. Some people report like anxiety when they take Sudafed as well, but you'll feeling like a little bit on edge. And that's really common. It will make people tachycardic generally as well. So if you feel like your heart's racing or you just like when I take Sudafed, I kind of feel like I don't drink coffee very often. Every once in a while I do. And when I do, I definitely, if I dose the caffeine correctly, I definitely feel it. And I feel similar to Sudafed, where it just feels jittery. I feel a little bit anxious, but it does keep me awake. And I do find that Sudafed actually works very effectively for vasoconstricting the respiratory mucosa and helping with the congestion symptoms. You can't get this just over the counter anymore because of people used to make meth out of it. I don't think people really make meth out of it anymore, but it was a big, easy way for people to make meth in clandestine laboratories. So it's become kind of a controlled substance that way. The topical alpha agonist, what I was alluding to earlier when I was talking about the sustained use of corticosteroid, these drugs are very effective for most people, but you should only use them for a few days because they're really potent topical vasoconstrictors. So oxymetazoline or Afrin, what happens after Afrin wears off is you get a rebound in vasodilation. So a lot of times people will feel even more congested after the drug's worn off, which makes it hard to kind of stop Afrin because you're like, oh my gosh, I just want to get to sleep. I know I used Afrin the last 5 nights in a row, but I really need to. But now I'm so congested. Sometimes you just need to bite the bullet, let the congestion wear off on its own. There are lots of reports of people sometimes are like, oh, you can get addicted to Afrin. It's not an addiction. What it is it's just trying to breathe. So it's people who have used Afrin for way too long, and all of a sudden, if they don't take Afrin, they can't really breathe out of their nose at all. Even if their cold's gone or whatever symptom or whatever thing that was causing it's gone, and it can actually damage your nasal mucosa too, to the point where it gets raw and you can get nosebleeds. Alternatively, you can actually use Afrin in a normal patient to treat a nosebleed because it should constrict the vessels. But those rebound vasodilations and constrictions and all that stuff can be harmful over time. So the bottle will say don't use for more than 3 days. I like to tell people if they're taking Afrin, you could use it maybe for 5 or 6 days, but just don't take it twice a day. So suck it up during the day. You're going to be congested. Maybe take Sudafed during the day. But use your Afrin in the evening only. Like when I get a cold, I use it to sleep, but I don't take it during the day. And I feel like that's kind of a nice balance where I can get a few more days out of it. But I do try and be really careful about letting it fully wear off to see really where my symptoms are. Because I do find that in the morning, it lasts about 12 hours. But in the morning when it starts to wear off, I can definitely feel that rebound congestion coming on. And I'll try and wait it out to see where my symptoms are. And I think that's the right way to do it. It's worked for me anyway. Epinephrine, you can give this in acute anaphylaxis. You can give it for other things too, but we can give IM or sub-Q, pure injectable epinephrine. It's very potent. You shouldn't ever give it unless somebody's in acute anaphylaxis. That'd be like an EpiPen. We can do it in the hospital too with drawing it out of a vial or an ampule. So, all right, that's it for this lecture. We'll talk about glaucoma, and then that's the two topics for this week.